So, hi all of you. I am Dr. Professor Lata, Professor for the Department of Obstetrics and Gynecology Nursing, and Vice Principal from M College of Nursing is going to present you on the topic Methergine. So, to have an outline on the presentation, we are going to see about the ergoid derivatives and its various constituents, Methergine, the onset of action of Methergine, how it is used, the indications, the different dosages and the modes of administration, contraindications, side effects, adverse effects, supply, store and dispense, drug interactions, its overuse and how it is treated, and various researches on oxytocin over Methergine. So as we know, the use of drugs have got a huge impact on the outcome of both and mother. It is always important to consider its use before administering during labor and pregnancy. So during the first trimester, as we know, it is a period of high risk, and especially between 3rd to 11 weeks of pregnancy. When you take drugs, it can cause congenital malformations. So during 2nd and 3rd trimester, so drugs can affect the growth and the functional development of the fetus, and therefore it can have toxic effects on the fetal tissues. So always we should have a concern and a wide knowledge of the drug to be used in order to safeguard the mother and the fetus. Now, to know about the ergot derivatives, as we know, ergot derivatives are the substances which is usually derived from a fungi. It is commonly known as an ergot. The name ergot comes from the French word called spur, which also means spur. Since when the grains gets colonized with the claviceps species, it resembles the structure of a spur on the legs of a rooster. So ergoid is a natural alkaloid of a claviceps purpura which grows on wheat, grains and rice. The first pure form of alkaloid was first described in 1875 by Tandret in France. So one of the constituents of ergot is an ergot alkaloid which is found to have more of a medicinal property, and we have lot of derivatives of ergot alkaloids which is commonly in use, and therapeutically one which we use is derived from the D-lysergic acid. So medicines containing ergot derivatives have an effect on the blood circulation, and therefore it has to be carefully used. And this is usually used for the mothers after the delivery of the placenta for the control of postpartum and post-bottle hemorrhage. Oxytocin is also equally considered important compared to a Methergine as a prophylaxis in the active management of 3rd stage of labor. So as soon as the drug ergot derivative is given, you can see the initiation of the action within 15 minutes when it is taken by mouth, and is more faster in onset when we use it by injection. Ergometrin is also called as an ergonovin, is a medication used to cause contractions of the uterus to treat heavy vaginal bleedings after childbirth. By the end of 19th century, ergot alkaloids were of no longer used during the parturition. So the commonly used ergot alkaloids in obstetrics includes ergometrin, otherwise called as ergonovin, and Methergine, methyl ergometrin and bromocriptine. So this is the drug which is available in the market as Methergine. So usually this Methergine comes in the name methyl ergonovin maleate. The brand name comes as Methergine, and it is, as we discussed, it's a group of ergot alkaloid, has got an effect on the smooth muscles of the woman's uterus, and thereby it improves the muscle tone, strengthens and increases the timing of the uterine contractions. Ergot alkaloid is either it can be natural or a semi-synthetic. So as we use Methergine, it is a semi-synthetic derivative which is obtained when there is a catalytic hydrogenation of the natural alkaloid. So it is used for the prevention and control of postpartum hemorrhage. Methergine is available in tablets for oral injection also for which is available as 0.2 milligrams methyl ergonovin maleate. So what should we keep in mind? So Methergine can be given both parentally as well as orally. So since it causes tetanic uterine contraction because it is a smooth muscle constrictor which is given for controlling as an active management of 3rd stage of labor, it is given after the delivery of the anterior shoulder of the baby or after the delivery of the placenta. So it should not be used in the induction of labor or abortion. Symptometrin also should be always administered IM. And if you take the preparations available, it is available in the form of ergometrin, methergine and symptometrin. Ergometrin, it comes as ampoules and tablets. In ampoules, it comes with 0.25 milligrams or 0.5 milligrams ampule. And as a tablet, it comes as 0.5 milligrams. Methergine comes as 0.25 milligrams as ampoules and 0.5 to 1 milligrams as tablets. Symptometrin is a composition of both ergometrin and symptometrin. So ergometrin 0.5 milligrams and 5 units of symptometrin together comes as ampoules. It doesn't come as a tablet form. If you look into the onset of action, when we give it through intravenous route, ergometrin acts within 45 to 60 seconds, whereas methergine acts within 5 minutes. To IM, it takes 6 to 7 minutes for ergometrin to have its function and methergine at 7 minutes. And for oral administration, ergometrin takes 10 minutes for its action and methergine takes about 10 minutes for its action. So how it is used in obstetrics, as we said, it is used for inducing the muscle tone. Since it is a smooth muscle constrictor, it increases the strength and the timing of uterine contraction, and in the postpartum period, it is usually given to control the bleeding and other uterine problems after the childbirth. How it acts when the ergometrin is given, it acts on the myometrium. The myometrial cells receptor are being stimulated so that it promotes the influx of calcium from the extracellular fluid from the sarcoplasmic reticulum into the cell. It causes increase in the cytoplasmic calcium. It stimulates uterine contraction and decreases bleeding. The common indication of this use of drug is that following the delivery of the placenta, we give it to manage the uterine atony, hemorrhage and sublumbration of the uterus as the commonest indication. So therapeutically, we do give it for that, and for prophylactic, in order to control the third stage of postpartum hemorrhage, we give it as an active management of third stage of labor after the delivery of the shoulders or following the delivery of the baby. Now, how it is administered? So both administered orally and parenterally. So as a nurse, before we start to administer any parenteral oral drug, we need to inspect visually for a particulate matter and a discoloration prior to administration. So intravenously or intramuscularly it can be administered. So usually we don't use intravenously until and unless it is there is a life-saving measure is present. We give it intravenously. So intramuscularly it is given after the delivery of the placenta. 1 milligram 0.2 which consists of 0.2 milligrams of methergine can be given, and it may be required as it can be repeated as per there is a need at intervals of 2 to 4 hours. So intravenously we usually give for the control of an atonic PPH. So as the same dose 1 ml consists of 2.5 milligrams of methergine should be administered slowly over a period of not less than 1 full minute, that is 60 seconds, which may be repeated after 2 hours. So why should it be administered slowly? Because when it is administered quickly, the effect of its function can be seen visible in a very quick way, and it causes more of serious side effects like the patients may get cerebrovascular accident or a myocardial infarction. So it should be administered very slowly. So some clinicians even recommend diluting the IV dose of 5 ml of this drug with the 0.9 sodium chloride injection before administration. So when do we give oral methergine is given only when there is excessive lochia and a subinvolution, where one tablet 0.12 milligrams 3 or 4 times daily in a puerperium can be given for a maximum of 1 week. And for a postpartum hemorrhage, we give 0.2 milligrams IM or an IV or every 2 to 4 hours. What is PRN? It is called as Pro-Renata, which is the drug is not recommended, but instead can be taken whenever it is required. So this is whenever it is required, it should not even exceed 5 doses, and thereafter 0.2 to 0.4 milligrams per oral every 6 to 8 hours can be given for 2 days, and thereafter whenever it is required, it should be given after 2 days to 7 days. Administration of IV is only considered in case of an emergency because the possibility of inducing sudden hypertension or a cerebrovascular accident is quite common, and therefore as a nurse's responsibility, we need to administer the IV methergine very slowly for No, well, not less than 1 minute. It should be more than 1 full minute, and with a careful monitoring of BP. So strictly intra-arterial or peri-arterial injection should be avoided. So contraindications when it should not be used. If you expect a plural pregnancy, a cardiac disease, severe preeclampsia or an eclampsia, induction of labor, first and second stage of labor, Rh negative mother, patients with hypersensitivity, suspicion of retained placenta, threatened abortion, severe or persistent sepsis, peripheral vascular disease, impaired hepatic or renal function, all these cases, the Methergine indication is contraindicated. So what are the common side effects that the clients usually say? The most concern adverse reaction that a nurse should have in mind is the hypertension. As we know, the drug is a smooth muscle constrictor. It can increase the BP within no point of time, which may lead to seizures and even headache. In some clients, hypotension is also indicated, and since it causes a tetanic uterine contraction, abdominal pain is more, and nausea and vomiting also occurs occasionally. So rarely observed reactions are acute myocardial infarction, transient chest pains, vasoconstriction, vasospasm, coronary artery spasm, bradycardia, tachycardia, dyspnea, hematuria, thrombophlebitis, water intoxications, hallucinations, palpitations, rash and foul taste are some of the common reactions that have been observed in the mothers receiving with Methergine. But the commonest one are given, or the other boxes name is nausea, vomiting, stomach pain, diarrhea, leg cramps, increased sweating, skin rashes, headache, dizziness, ringing in the ears, stuffy nose, or even unpleasant taste in mouth are all the reported common side effects with the use of the drug Methergine. So as a nurse, what we should be concerned is about the rise of the BP, and when you use it for a long period in puerperium for treating subinvolution excessive lochia, it may decrease the concentration of prolactin, and thereby also it has a chance of increasing the gangrene on the toes because of a vasoconstriction. So it is also how it is supplied. So usually a oral tablet comes in a white round biconvex compressed tablets debossed with N on one side and 0,1 on the other side. It is available in bottles of 7, 12, 28 and 100 tablets. Bottles of 7 comes with a national code which is given here in the slide. And how it is stored? It is stored below 25 degrees centigrade in tight light resistance container. So Methergine ampoules usually comes as 1 ml, which consists of 0.2 milligrams of Methergine. It is a colorless solution, and the manufacturers are the Novartis India Limited, which consists of 0.2 milligrams of methyl ergometrin. It is available in the market at Methastar, Ergolin, Methygen, etc. So it should be stored in a refrigerator between 2 to 8 degrees centigrade but should not be freezed. So as a nurses, we need to know the drug interactions of Methergine when given along with the other drugs. So when given along with macrolide antibiotics and protease inhibitors, it results in vasospasm leading to cerebral ischemia or ischemia of the extremities. When given with nevirapine and rifampicin, it increases the pharmacological action of Methergine. When given with beta blockers, it may enhance the vasoconstrictive action of ergot alkaloids. When it is given with anesthetic agents, it reduces the oxytoxic property of the Methergine. When it is given with other anti-anginal drugs and glyceryl trinitrate, it reduces the efficacy of these drugs because of vasoconstriction, and therefore these drugs will not act as a life-saving measure in case of clients with emergency. So how should we use in pregnancy? So don't ever think that ergometrin can be used as a drug to induce labor. Okay, so it causes uterine contraction, and if it is given during pregnancy, it may lead to premature parturition or an hypertonic labor. So if it is given during pregnancy, and because it causes tetanic uterine contraction, there may be decreased uterine blood flow, and thereby the fetus can go for fetal distress. Products containing ergometrin should therefore be avoided as far as possible during pregnancy. So how it is used in labor and delivery? Ergometrin should not be administered prior to delivery of the placenta. Before the IV use of ergometrin during severe bleeding, inspection must be made for placental fragments. High doses of ergometrin administered prior to delivery can cause an uterine tetany and problems with the infant due to low supply of oxygen leading to hypoxia and intracranial hemorrhage. If administered during second or third stage prior to the delivery of the placenta, it may lead to complications like decapitation of a placenta, or sometimes we may miss out the second baby in case of a pleural pregnancy because of the quick uterine contraction that occurs after the use of drug by intramuscular way. The placenta should be delivered and the possibility of twin pregnancy should be strictly ruled out before you administer the ergometrin. So overstimulation during labor can cause uterine tetany. Sometimes it may lead to uterine rupture, cervical or perineal lacerations, or amniotic fluid embolism and infantile trauma. So it should be used with care during labor and delivery. So as a nursing considerations, as we know, it causes a smooth muscle constriction. The nurses have to check the blood pressure, pulse, respiration and the signs of hemorrhage before administering the drug. Always administer it orally and IM deep. Evaluate the decrease of blood loss after the use, and always advise the patient to report of the side effects that they feel, like increased blood loss, abdominal cramps, headache, sweating, nausea and vomiting, etc. if present, have to be reported to the physician or the nurses immediately. Now, since there is a chance of overdose because we cannot measure the level of methergine in the blood, chances of overdosage may occur, and as a nurses we need to know the manifestations of a overdose. So the serious overdosage manifestations are convulsions and gangrene formations. So others may include bradycardia, confusion, diarrhea, dizziness, dyspnea, drowsiness, fast or weak pulse, meiosis, hypercoagulability, loss of consciousness, nausea and vomiting, numbness, sometimes cold in the extremities, pain in the chest, peripheral vasoconstriction, respiratory depression, rise or sometimes fall in the blood pressure, severe cramping of uterus, tachycardia. So all these tells there is a overdosage symptoms as a part where we need to be really careful in monitoring them in the clients, those who receive more methergine for more than 7 days. How should we treat this overdose? There is no antidote for the management of ergometrin overdose, whereas a supportive and symptomatic treatment should be initiated. So if ergometrin, you feel it is overdose, stop them immediately. So convulsion should be treated with anticonvulsants like phenytoin and diazepam. Hypercoagulability should be controlled by the administration of heparin, and severe hypertension have to be treated with sodium nitroprusside and hydrolzone. Peripheral ischemia may be treated with sodium nitroprusside and phenethylamine. Gangrene may require a surgical amputation. If the client experiences a myocardial ischemia or a hypertension, a vasodilator have to be given. An ECG monitoring may be required in order to assess the cardiac function and perfusion, and frequent monitoring of vital signs as well as the blood gas and electrolytes is recommended. Monitoring of serum ergometrin levels is not predictive of the outcome of overdose. If it is not known, in use of a forced dialysis, peritoneal dialysis, hemodialysis or charcoal hemoperfusion will hasten the elimination of ergometrin, especially if you consider the drug is an overdose. Now the WHO recommends, instead of methergine, it recommends oxytocin 10 international units IV or IM is recommended as a uterotonic drug, which is given as a part of active management of third stage of labor for the prevention of PPH. Now, what is the difference between the drug ergometrin and oxytocin, and why WHO has recommended oxytocin? Because of the various actions which we will see now. So the onset and duration, ergometrin immediately within few minutes starts its function and it lasts for 20 minutes, whereas oxytocin has got a shorter onset and its half-life is only a few minutes. So whereas ergometrin causes a contraction of the vascular smooth muscle, whereas oxytocin causes a relaxed smooth muscle. Peripheral compliance is increased in ergometrin, it is decreased in oxytocin. Heart rate, there is no influence with ergometrin, but it is increased in oxytocin. So CVP is increased both with ergometrin and oxytocin. BP is increased in ergometrin, whereas it is decreased in oxytocin. Epidural pressure is seen to be increased in both the drugs. So why oxytocin over methergine? So the Cochrane Library Reviews tells that oxytocin tries to reduce the blood loss as well as it reduces the need for additional uterotonics Well, it is given prophylactically in the third stage of labor, and therefore it is considered to be an active component of an active management of third stage of labor. The side effect profiles is favorable for oxytocin when so compared to a methergine, and therefore the risk have to be weighed when we try to decide either between an oxytocin or a methergine. So there is no clear benefit of oxytocin or ergot alkaloids with regard to blood loss. So a study conducted by Dripa Rajendran and et al., where she tried to compare the oxytocin versus methyl ergometrine of clients in 100 pregnant women with a gestational age more than 37, revealed that the intramuscular oxytocin is equally effective as that of an methyl ergometrine. So hence it is more preferable prophylactic uterotonic management because oxytocin has got a better safety profile. Since both are effective, but oxytocin has got a better safety profile compared to methyl ergometrine, and it can be recommended as a good uterotonic agent for the active management of third stage of labor. So the another study by prophylactic conducted by S. McDonald, J. M. Abbott, and S. P. Higgins states that the prophylactic comparison of ergometrine and oxytocin on PHE states that there is no difference between these two drugs in case of the efficacy and the blood loss, but the maternal side effects, including a high blood pressure, vomiting, and nausea, is associated more with ergometrine compared to oxytocin, and therefore the advantage of risk reduction of PPH along with the others have to be clearly weighed before we try to administer or have a choice between ergometrine or an oxytocin. So to come to a conclusion, so both methyl ergometrine and oxytocin are equally efficacious. But oxytocin has got all other advantages of ease of administration, significantly a better profile, a lesser contraindications for usage. So it is concluded that intramuscular oxytocin is more preferable for prophylactic uterotonic in the active management of third stage of labor. Still, more of high quality trials has to be conducted on how to dose or the routes of oxytocin, its function or the outcome or the maternal mortality shock, and transfer to a higher level of care is absolutely required. A network of meta-analysis of uterotonics for PPH prevention plans have to be addressed around its dosage, the routes, and other uterotonic aids. So both are equally effective comparing to the maternal side effects. So WHO has suggested that oxytocin is very effective and can be considered as a very good uterotonic drug in the management of active third stage of labor. So thank you all. So these are the references that I have used, and I convey my sincere thanks for everyone for your kind attentions toward the end of this presentation. Thank you, one and all.